Last time we discussed the signs, symptoms, and embryology of the uveitis. Come, one or two questions regarding that, the last topic. What is aqueous flare? Anybody from the front here? Aqueous flare is the sign of uveitis, no? Acute uveitis. What is that? If I ask, what is aqueous flare? Speak loudly, little bit. Anybody else? You can speak loudly from the front back. Aqueous flare is a turbidity like that, even though a Tyndall's effect. But why it is occurring that? Why it is presenting there? So due to what? This is the proteinous material that comes in the aqueous, that's suspended in there. That causes the turbidity of the aqueous. That is the important sign of acute uveitis. We can divide in the +1, +2, +3, +4, depending upon the how much turbidity is there. What are the structures is to be seen. Whether we can see the posterior structure. Posterior structure means lens, capsule, iris part. We can see. If we cannot see, it means turbidity or concentration of that protein material is too much. We cannot see the structure, or the vision is low. That is aqueous flare. A proteinous material that is comes in the aqueous. That is the aqueous. These are the normal questions, usually questions which are asked in the examination, the practical. And same thing, what is KPs? Have you heard about, no? The last time I explained. What is KPs? These are the cellular deposits at the back of the cornea. That is KPs. Depending upon the color and the type and the thickness and the size of that, it can be mutton fat, the fine KPs, the coarse KPs, crenated KPs, or the red KPs, or like that. That is also important signs. You see under this little lamp, these two signs are very, very important for the acute uveitis. Aqueous flare is present. Think about from where it has come, because the change in permeability of the iris vessels or ciliary vessels. Cells deposition comes because it's same structure that pathology that. The classification, everything which we have seen. One more thing is important, torchlight examination. That is the circumcorneal congestion. Pain, redness, photophobia, that is another thing. But important features, circumcorneal in acute iridocyclitis I am talking about. Circumcorneal congestion will be must. KP and flare, slit lamp examination, then we can diagnose some certain other things, corneal signs, iris signs, the pupillary signs, synechias, the ventricular, and so many complications, posterior uveitis, choroiditis, or CME, or macular degeneration, or detachment, or like choroiditis, or like that. That should know. Sorry. Okay, the complication serial wise, starting from that. One more question. What is late? There are two types of glaucoma. One is the early glaucoma, another is the late glaucoma. What is this late glaucoma? Tension increases in the uveitis part. One is the early, means immediately after 3-4 days or 4-5 days. The late is whenever after 10 or 15 days, whenever some complications occur. What is that? Late glaucoma. Okay. Early is because the cells and aqueous, this is proteinous material, they are going in the trabecular meshwork that clog, that obstruct the channel, UV scleral, the trabecular scleral outflow. That is early glaucoma because the obstruction in that outflow process. The late glaucoma, when the synechiae develops, all that, because the filtration is less that. Aqueous comes in the anterior chamber, but through that canal of Salem, the trabecular meshwork, it cannot go because the synechiae cannot go in the angle. That is the late glaucoma. These are some important signs. Make a habit whenever we are or anybody is taking class, go through that, so that at least some salient features on that, some important features you can remember that. That is why I am asking whether you know or not, or that lecture has gone. Whatever I have taught, that has gone. Now you will read in the examination part only. So make an habit. Try to. Okay. The last part of this uveitis, we are discussing the all lab diagnosis and treatment part and differential diagnosis of this one. Okay, investigation, signs, symptoms, and the complications we have seen. These are some investigation. There are so many things that we are asking. Once a patient of acute iridocyclitis comes in the OPD, that these are some investigations, so that we can know that what is the cause of that. Generally, there are two types of this iridocyclitis that we have explained the last time also. One is the granulomatous, another is the non-granulomatous. Means granulomatous is usually infective, like tuberculosis, syphilis, and other parts of this. That is the granulomatous part. And non-granulomatous, this is acute, and that is usually allergic part of that. Behçet disease, ankylosing spondylitis, heterochromic uveitis, or like that. It is allergic in nature. That is why we will see the difference between these two. But broadly speaking, granulomatous is a early chronic disease, and mostly this is infective also. And the non-granulomatous is the acute in nature, and that is allergic part of this. Most common cause in the young adult is the ankylosing spondylitis, and another part the heterochromic uveitis or Behçet disease, that including the skin also. These are some common causes. Like in the children, this allergic part non-granulomatous is the idiopathic rheumatoid arthritis. This is a common cause. So we'll think about, according to age and according to whether the glaucomatous or non-glaucomatous, we can think of what can be the probable cause of this one. That these are the differences we'll see in that today's lecture. So what investigations we'll prefer once a case of that will come? Because almost whatever the disease, systemic disease or eye disease, that is the so these are, every disease causes the uveitis part of it. So these are some common tests which we are asking for when the patient comes. The blood test, TLC, DLC, ESR, blood sugar level, uric acid, serological test, syphilis, toxoplasmosis, histoplasmosis, test for anti-nuclear antibodies, the RA factor, Ali cells, C-reactive proteins, and the streptomycin O. Every test has its own value that. Take an example, the TLC, DLC, any inflammation, the chronic or acute, these are the raised part of this neutrophil, atropine, and like lymphocyte like that. What is the importance of ESR? Why we are asking the ESR? Suppose the ESR is raised 40, 50. What will you think of? Because these things should be in your mind. Why we are ESR, TLC, DLC, stool test, urine test, serological tests? Because these are the some diseases which are causing this uveitis part. Chronic inflammation, the acute inflammation, that is the TLC, DLC is raised that. Leukocytosis or other part. ESR is the so important diseases. What is that? Important. Tuberculosis. Right? The chronic infection ESR is raised too much that. That is why. Just to differentiate between sarcoidosis and this one. Tuberculosis. It's an important diagnostic feature. That is why we are asking for. Like Ali cell or anti-RA factor or anti-nuclear antibodies. Which disease you want to know? These are the immunological disease. Anti-nuclear antibodies, rheumatoid factor, idiopathic. That is why we want to know that. Ali cell phenomena, which are allergic in nature or idiopathic cause. urine examination also, some UTI here, like that. That also causes uveitis. Stool examination, and cyst we are asking them. That is also important. Radiological examinations, important. Ankylosing spondylitis, lumbosacral spine. We are asking for this, or lumbar spines. That is why we are asking these things. Skin test, tuberculin test. Tuberculin is for tuberculosis. We are injecting here, and we are seeing that in duration after 72 hours. If that is raised more than 10, that is suspected acute case of tuberculosis. That is why we are asking stream test and toxoplasma test. So these are some routine tests we are asking for that. So whenever the case comes, routine investigation, sugar, TLC, DLC, ESR, X-ray chest, lumbosacral spines, sacroiliac joint, and skin test, the ova and cyst for the stool, and the urine test, we are so that we can have a clue that. That is why these are important. If the question comes, what is the investigation you are doing? These are some common investigation you have to write in your answer. Differential diagnosis will take at the last. And granulomatous and non-granulomatous, that also. We will discuss the treatment part, because the signs, symptoms, and we have seen everything. The diagnosis we have done with the lab investigation and all tests are done. We have diagnosed. This is a case of acute iridocyclitis. Then how will you treat that? If the cause is known, means suppose you have done the X-ray test and you have stream test, Montauk test, and ESR is raised, we have diagnosed this is a tuberculosis case. Tuberculosis the patient is having, this uveitis is due to the tuberculosis or syphilis. Then we will start the treatment of this. Anti-tubercular drugs we will start that. If the syphilis, penicillin, and other things. That is why these are important things. Once we diagnose the case, whether this is granulomatous or the non-granulomatous or infective or the bacterial or like that, then so that we can start. But there are some common measures we will start that before investigation, before diagnosing the case. So these are some special treatment part. To almost every case, we have to start these things. And that is one, local therapy. We have to start this. Local therapy means topical therapy. We will start that. Mediatic drops, this is cycloplegic drug, corticosteroid, the broad spectrum antibiotic drops. That we have to start immediately, whether we have diagnosed the case or not. But uveitis is there, that we have seen that. So we will start these things. Cycloplegic drug, steroid, and antibacterial or antibiotics will start. Systemic therapy also will start. Corticosteroids or the non-steroid anti-inflammatory drugs or immunosuppressive drugs. Physical measures, some hot fermentation and the dark goggles. These two things are important part. We will start that. Why hot fermentation? What is the logic behind this hot fermentation? And dark goggle? Because whenever we are writing hot fermentation, we will start that. And dark goggle will prescribe. Then we will ask you why? What is the logic? What is the reason? How they will help that? Hot fermentation. Suppose there is a boil like that. We are asking for the hot fermentation that. Because this is the inflammation part that has gone. More circulating blood part. So that the toxic material that will wash away. That will help. Edema will be reduced with the hot fermentation. Whatever the circumcorneal congestion is there, that may be reduced a little bit. And that gives a soothing reflex, soothing part also to the eye. Some pain relieving also. So more increase circulation part, that is pain relieving, a physical measure that. And the dark goggles, because it light is bright light that goes photospasm, photophobia, that will prevent. That is why we are prescribing. Although they are not very important part of the treatment, but some measures, outside measures, just to give some relief to the patient, we can start that. Why there is a photophobia? Because the pupil is constricted, pupil cannot react, there is no protective phenomena. Whatever there is dark light, sharp light is gone, I will be close that. Just to prevent that. Sharpness of the light that will prevent the dark goggle. That will help that. Then coming to the other part, specific treatment of the cause, suppose that we have seen, suppose syphilis and glaucoma, is it tuberculosis, we will start that. Treatment of the complications, we have seen so many complications, complicated cataract and early glaucoma, the late glaucoma, exudative, CME, or this is macular degeneration part, or choroiditis, or retinal degeneration, or retinal hole, like that. These are some complications that will treat them separately that. Because the question comes, enumerate all complications of the uveitis. Then you have mentioned, and how will you manage that part? So accordingly, with the disease, whatever they know. Suppose you have written complicated cataract in the complication. Then you should know how the cataract is treated that. Take that, order that. Then with surgery that, implant the lens, cataract will be removed that. Glaucoma, then some anti-glaucomatous drugs, and then you can do the filtration operation. That is how we can treat that complication part. But we should know that what are the complications of this one. In detail, mediatic or cycloplegic drugs. You should know the difference between, because these are the common questions we are asking for that. What is mediatic? What is cycloplegic drugs? Mediatic is the pupil dilate. These are the mediatic drugs. All mediatics will not produce the cycloplegia. What is cycloplegia? What is cycloplegia? All are silent. It's a loss of accommodation. And the pupil dilates, cycloplegic drug. Can anybody name that one drug which is causing the dilatation of the pupil but not cycloplegic drug? Any drug which is mediatic, means which causes dilatation of the pupil but no cycloplegia, no accommodation loss. Accommodation is by ciliary muscles. So these muscles are not paralyzed, cycloplegic drug. No, that is the phenylephrine. That is the mediatic, but no cycloplegic drug. That will be start that. Okay, you people are not replying that. So I'll switch on this. Atropine sulfate, we will start that. Atropine drops 1% instead 2 to 3 times. Then comes the homatropine also, atropine, homatropine, and the midricane cycloplegic drugs. We will start that. Immediately, first line of treatment, we will start the cycloplegic drug. Not the phenylephrine, but atropine or homatropine or cyclopentolate. These things we will start. We should be cycloplegic drug because we want to relieve the pain. We want to relax the ciliary muscles. That is one important, because that causes the spasm of the ciliary muscles. One important part. And another part, so how these cycloplegic or the atropine, because whenever you say the atropine or cycloplegic drugs we are starting, how it acts, what is the mechanism of action, that also you should know that. These are the common questions which are asked. One, it gives rest by the relieving spasm of the ciliary sphincter and the ciliary body, dilatation of that. So it relieves the pain and the spasm of this one. Prevents synechia formation and breaks the synechia. So the total synechia, it prevents, or whatever the synechia is formed, it breaks that. Two actions. Third, reduces the exudation by the decreasing hyperemia and the vascular permeability. Reducing the vascular hyperemia, because the exudation of the cells, they are coming in the aqueous cells, and the cells will be there, and the exudating membrane, the pupillary area, that will be reduced by this. It prevents the exudation of the cells by the hyperemia. Increases the blood supply to the anterior uvea by relieving the pressure on anterior ciliary arteries. As a result, more antibiotic reaches the target tissue and the more toxins are absorbed. These are the 3-4 mechanisms of action. One, it relieves the spasm of the ciliary muscles and the sphincter pupillae. It prevents synechia and it breaks synechia. It gives less exudation of the cells and it gives it more antibiotic in that part. That is how these are acting on that. So pain will be reduced, hyperemia will be reduced. That is how these act. Or synechiae will be break up. It prevents the synechiae formation. That is how atropine, homatropine, or cyclopentolate and cyclopentolate they act. Corticosteroids. Corticosteroids are, if you have read in the pharmacology, three main action: anti-inflammatory, anti-allergic, and anti-fibrotic action. That anti-allergic, anti-inflammatory, and anti-fibrotic, we are starting there because it is the inflammation of that, so that we are starting there. So many types: dexamethasone, short-acting, medium, and the long-acting. That we will start topically or as well as systemically also. The local as an anti-inflammatory, anti-allergic, and the anti-fibrotic agent. Commonly used steroids are dexamethasone, betamethasone, hydrocortisone, and the prednisolone. That 4 to 6 times we will start vigorous therapy of this. Systemic means whenever this tablet form or the IV form. There are 3-4 indications of the systemic steroids. One, if there is a bilateral uveitis, bilateral acute iridocyclitis. If the one is in the one eye only, we can start only the topical steroids or the dilator. What when there is a bilateral? It means some systems are involved through the blood. Then we have to start systemically also, oral or IV or like that. If posterior part, the posterior uveitis is there, because the topical drug cannot reach posteriorly, means to the vitreous and the corridor, the retina, that. Then we have to start systemic alone. Or whenever there is no topical drug is acting, no relief by topical drug, then we have to start the systematic drugs. So 3 indications: if there is a bilateral case of uveitis, we will start steroid systemically. That posterior part is involved, that is. Or recurrence also, whenever there is a recurrence, then we will start. Or if they are topical drugs, patient is not responding well, we will start the systemic drugs also, dexamethasone or prednisolone or methylprednisolone. We have to start these things. So 2 drugs important whenever the case of the iridocyclitis is diagnosed. We will start steroid and cycloplegic drugs. Antibiotic many times have no role, because suppose this is the allergic, this is not infective, then antibiotic has no role. But in the allergic or other part, these steroids and the cycloplegic drugs will definitely giving the help to the patient. Broad spectrum antibiotics we are also starting. Antibiotics are used to with steroid to provide an umbrella cover. Suppose the diagnosis is not there, we are not sure that this is infective or the allergic, then steroids and these things under the umbrella of the antibiotics will start that. Moxicillin, floxacillin, tobramycin, getafloxacillin are used with the steroid. Non-steroidal anti-inflammatory drugs like aspirin, phenylbutazone, oxyphenbutazone, and local flurbiprofen, ketorolac drops are also used as anti-inflammatory drugs. These things can start also. But important part is the steroid and cycloplegic drugs that will start. If anybody asks you what is the indication of steroid, which disease, this uveitis is the one part. Ulcer, in the ulcer especially, we are not starting steroids there. Remember that. Then there are immunosuppressive drugs. Some drugs we are starting, they are immune mechanism just to suppress that immune mechanism. These drugs should be used as serious cases or where the steroids have failed to resolve the inflammation and the danger of blindness. These drugs are dangerous and should be used with great caution and the supervision of the hematologist and oncologist, because they are having too much toxicity of this. Oncologists, thus they are starting these drugs. But we have to start them with the supervision of oncologist or hematologist. These drugs are usually, especially in the cases of Behçet syndrome, when the skin or Johnson syndrome or like that. One, sympathetic ophthalmitis, due to the response of one, other eyes involved. Pars planitis, idiopathic etiology. VKS syndrome, Vox-Konegy-Heradas disease. So these are some diseases where we are starting these immunosuppressive drugs. These drugs are cyclophosphamide, chlorambucil, azathioprine, and the methotrexate. Cyclosporin is powerful anti-T cell drug but highly renal toxic drug. So these are the drugs that we are starting that. Then we can ask you what are the immunosuppressive drugs and in which disease we are starting this. So these drugs are 4-5 drugs: clombazole, azathioprine, cyclophosphamide, cyclosporin. These drugs we are starting in special cases, special etiological cases, that these are sympathetic ophthalmitis, Behçet disease, pars planitis, like that, or VKS syndrome, especially in that. Not in every cases. Suppose there is a granulomatous tuberculosis cases, these things are not to be started that. These special cases, or whenever steroids and cyclophosphamide drugs are not responding, then we will start them. But with the great precaution, with the help of hematologist and oncologist, we are starting that. So remember these names and indications of the diseases of this. Treatment of the causes. Once we have diagnosed this cause is that, then we have to start the drugs like anti-tubercular drugs and Cox disease. Suppose the tuberculosis we have diagnosed, then we will start anti. Three things are that is isoniazid and ethambutol and the toxic and other thiacetazone, we will start that. Syphilis, toxoplasmosis. When no cause is found, full course of the broad spectrum antibiotic may be helpful by eradicating some focus of the infection in some patient with non-granulomatous uveitis. If the cause is not diagnosed, not known that, then with the broad spectrum antibiotic, with the steroid, we are starting that. If the diagnosis is particular about this is the Cox or syphilis or toxoplasmosis, then we will start particular the drugs that, like the toxoplasmosis or the Cox or syphilis or like that. Then we will start these. Then lastly comes the treatment of complications. The same thing we have discussed in the last time. Inflammatory glaucoma, one is late and synecdoche formation like that. Post-inflammatory glaucoma, complicated cataract, treat that like cataract formation. Retinal detachment is separate with retinal surgeon and remove the laser complication, buckling and that tuberculosis or vitrectomy. Choroiditis, same thing. Papillitis, steroids are indicated in that. Thysis bulbi and no cause, and many times it is painful. We remove that cause. That is the treatment of this part. Suppose a case comes to the OPD and that is the flare and the aqueous part is known, and we have diagnosed this is a case of acute iridocyclitis. So some routine investigation will send that, because the report will come in the 1 or 2 days. By that time, we will start 2 drugs importantly. One is the steroid, immediately start topical steroid, and the cycloplegic drug. Whatever the steroids or the bilateral or posterior part, then we can start the systemic also, oral drugs. That will start the treatment of it. By that time, investigations are sent. Suppose something comes, suppose this is the tuberculosis or syphilis or part of that, then we will start the particular treatment of that part. Ovasis, toxoplasmosis, like that, we will start the treatment of this. So the one's case, sign symptoms, investigation, complications, and we have known, and the treatment we have discussed about this. That is all about this uveitis part, the investigations and the sign symptoms, treatment and the complications and investigation, all part of this. Now comes the differential diagnosis of this one. Yes. Important part is the granulomatous and non-granulomatous uveitis. Usually granulomatous uveitis, where this granulomas are formed, this is generally infective. Either it can be syphilis or it can be tuberculosis or some disease, sarcoidosis. This is non-infective part. And non-granulomatous is acute in onset. That is generally by allergic in nature. There are some exceptions. Suppose there is a non-granulomatous, I have spoken that this is allergic in nature. But there are some bacterial viral infections, varicella and that causes. These are infective viral causes, but they cause acute non-granulomatous uveitis part. That is the exception of this one. Like that, granulomatous uveitis, they are generally infective, like tuberculosis, syphilis, but one disease is sympathetic ophthalmitis that is not infective. That causes the granulomatous uveitis, tubercle formation there. That is exception. Or VKH, Vox-Koenigsberg disease, that is also allergic in nature, uveitis. So some exceptions are, but usually remember the granulomatous is infective and non-granulomatous is allergic in nature. So we have divided this in one part of the granulomatous, another part is the non-granulomatous. How will differentiate this thing? Because these things are to be asked. How will you differentiate between granulomatous and uveitis? Suppose the case is given to you. These are the findings fixed, whether this is granulomatous or this is non-granulomatous. How to diagnose this thing? There are certain features, certain characters of this. Like these are discussed. One is the onset. Granulomatous is insidious in onset, chronic in nature, and that is non-granulomatous is acute in nature. Pain will be minimal in granulomatous and marked in non-granulomatous. Photophobia, slight in the marked. Ciliary congestion will be more marked in the acute and minimal in granulomatous. Then other features, important part, KPs, mutton fat KPs are more common in granulomatous because the mutton fat KPs is a large size, white, the grayish in color these are. That we have seen that a large size of mutton fat KPs are there. These are the features of granulomatous uveitis. While in non-granulomatous will be small, fine KPs will be there. Iris nodules, coppas and Basaka's nodules more common in granulomatous uveitis. Posterior synechiae is thick in granulomatous. Why is very fine the tenuous in non-granulomatous. Fundus picture, the nodular lesions can be seen and the diffuse involvement in the non-granulomatous. So these are some differences. Suppose a case comes to you. Patient gives a history of acute onset. 3-4 days, 5 days history, pain, photophobia, diminution will be acute in nature, 3-4-5 days. We'll think of it can be acute in nature and there will be non-granulomatous. Just make a picture. Then you see whether the circumcorneal congestion is marked or not. If there is a less circumcorneal congestion, think about granulomatous because this is the chronic in nature. Acute will be more pain in acute part. Or KP, the mutton fat will be more size of KP, that will be. The synechiae are very thick, more in granulomatous. Or if you see the nodules, iris nodules or Basaka's nodules, more common in granulomatous. So immediately we will have a picture that it can be granulomatous, it can be non-granulomatous. Those synechiae are more pain, say circumcorneal congestion or the nodules or other part, that is more common in non-granulomatous, granulomatous part. So that we can diagnose these things. Treatment immediately we will start that steroid as well as the cycloplegic drugs we have to start. But once we have diagnosed this is the granulomatous and syphilis or tuberculosis with the diagnosis, then we have to start the specific drugs also. Anti-tubercular drugs we will start, and for the syphilis, penicillin or other part we have to start. That is how the diagnosis is very important and the lab investigation. Clinically we can judge, but we have to diagnose this. Non-granulomatous, acute, steroids are must. Non-granulomatous, the tubercular or syphilis, then these will be, other things will be helpful. That is a differential diagnosis of granulomatous and the non-granulomatous. Because this is important, because in the theory part we can ask you, write differences between the granulomatous and the non-granulomatous uveitis. Or suppose the case is given to you, or this is iridocyclitis, we can ask you how will you differentiate the granulomatous or the non-granulomatous? What are the features of this one? How will you treat? How will you differentiate? That is why this is very important part of it. Second differential diagnosis will be red eye. You know, many times this red eye is there, we can ask you all questions is complete the ophthalmology part. So many causes of the red eye, allergy, trauma, congestion, infection or whatever they are. But important things, differential diagnosis of red eye. There are 3 causes, important causes. One is the acute iridocyclitis, another is the acute conjunctivitis, and another is the acute congestive glaucoma. That these things, how we'll differentiate this? These are practically important things for the clinical point of view. Take three cases. One is the acute conjunctivitis, another is acute uveitis, and lastly that is the acute congestive glaucoma. Because the diagnosis is important, otherwise we'll mistreat the patient, wrongly treated the patient. Take an example. Suppose there is a case of, because we have not covered the acute congestive glaucoma, but salient feature we should know that. Acute congestive glaucoma is where the tension is very high. Pupil is fixed and dilated vertically over that. Patient is having vomiting and the pain and like that. Tension is very high. If in that cases, suppose we misdiagnose, if we diagnose acute iridocyclitis and we start cycloplegic drugs, atropine or homatropine, people will be dilated. Already there is a dilated, people will be well dilated and that will obstruct the trabecular meshwork. Tension will be raised too much. Patient will be in agony. Because the treatment of acute congestive glaucoma like Diamox is pain reducing, the tension reducing cases. So the tension we have to check that. Tension will be very high in acute congestive glaucoma. Congestion, superficial congestion in conjunctivitis and the circumcorneal congestion in uveitis and that one. AC differences, AC will be normal but could be very shallow in acute congestive glaucoma. People see the pupil size, festoon shaped pupil in acute congestive glaucoma, normal in acute conjunctivitis, and the AC shallow will be in acute congestive glaucoma. Pain will be more, vision diminution will be more, or discharge. Acute conjunctivitis is bacteria that is having acute conjunctivitis is discharge. There will be no discharge in acute conjunctivitis, uveitis and the acute congestive glaucoma. So that by seeing the tortoise examination, we can diagnose, we can suspect that. Suppose you are at the periphery and we don't have slit lamp there. You are simply MBBS and we have the training, internship training there. Suppose a uveitis or the glaucoma, acute congestive glaucoma, because these cases can be because you are only the physician and surgeon there and you have to diagnose that. Suppose the patient comes, too much pain is there and there is no discharge like that. If you feel digitally there is tension is very high, suspect this is a case of acute congestive glaucoma. And don't start to treat this one, atropine or homatropine. That will aggravate the condition. Or with the torchlight, if you can see the pupil. If the pupil is constricted or synechias, you can see that, then this is uveitis. If the pupil is well dilated, vertically oval, then acute congestive glaucoma. So by seeing these things, we can avoid the worsening situation. Conjunctivitis, there is no different conjunctivitis, we can start the antibiotic drop. If hardly if you are starting steroid, that will make no too much difference. But if you start that in glaucoma cases, atropine or homatropine, that will aggravate the situation. So that is important how to diagnose this red eye, this the acute conjunctivitis, the iritis, or the acute congestive glaucoma. Treatment is different. More details when we will discuss the acute congestive glaucoma also. Because now we have seen the conjunctivitis, we have seen acute iridocyclitis, we have seen. Because in the theory part we have not covered the acute congestive glaucoma, the glaucoma narrow angle or open angle. So that whenever these topics will be clear, then we will discuss separately the differential diagnosis of this red eye, that in emergency side. So that we can diagnose this iridocyclitis or the acute, what are the features of narrow angle glaucoma, the open angle glaucoma, acute congestive glaucoma, how to treat, what is the difference between that. But broadly we should know that AC is shallow, tension is very high, diminished vision, circumcorneal congestion, vomiting, like that features we are seeing that. So this thing that will finish the acute, this one, uveitis part, the conjunctival part. And this, I think next time we will start a separate topic, the corneal part.